Welcome to Crack Surgery. Today we are going to discuss a very important topic, that is CA breast. Introduction. It is the most common form of cancer affecting middle-aged women mainly in western country. Previously, CS cervix in is the most common form of cancer in female. Now it is superseded by CA breast. Every 1 in 12 females affected by CA breast in United Kingdom. Incidence rate. Females are more prone to affecting CA breast than the male. Male to female ratio is 1 to 99. Western countries are more affected than eastern countries. Commonly, we see CA breast in 35 to 55 age group women. If there is a younger patient, there is may have family history of CA breast. Before menarche or after menopause, CA breast generally not seen. 20% occurrence is seen in women more than 90 years of age. Developed country, high socioeconomic strata are more affected towards say breast. Etiology. There are three gene mutations responsible for the CA breast. First is BRCA1, that is BRCA1, present on 17 chromosome. It associated with hereditary breast carcinoma and ovarian tumor, also associated with medullary carcinoma, triple negative carcinoma, that is basal carcinoma. Second is BRCA2 or BRCA2, which present on 13 chromosome. In male breast CA, BRCA2 is more common and also associated with luminal A and B type of carcinoma. Third gene mutation responsible for the CA breast is P32 gene absence. When there is no family history of having CA breast, there may be chances of P32 gene mutation and also associated with sporadic breast cancer. It is commonly overall in not most common in overall mutations is P53. Another genes responsible for CA breast is CHEK2, CHEK2 gene mutation, which is usually associated with radiation associated breast cancer. Now, family history. First degree relatives are more prone to having CA breast. Diet: low in phytosteroid, low in micronutrients, low in citrus fruit, or high intake of alcohol may contribute in the formation of CA breast. Other factors such as endocrine dysfunctions, nulliparous women, obesity, long use of oral contraceptive pills, patient on HRT, early menarche, late menopause are responsible factors for CA breast. Early first child and breast feeding are protective against CA breast. Now we are going to discuss the classification of breast cancer. The classification can be classified in two categories, that is molecular classification and histological classification. First, we discuss the molecular classification, which subdivided into 5 types. First is luminal A type carcinoma, second is luminal B type carcinoma, third is HER2 positive carcinoma, fourth is basal carcinoma, fifth is associated with Claudine, sorry, G is not present, Claudine. First is luminal A carcinoma. There is HER2 negative, PR positive, that is estrogen receptor positive, progesterone receptor positive, usually associated with BRCA2 gene mutation, and it is better prognosis. Luminal B carcinoma, there is HER2 positive, AR positive, PR positive, and associated with BRCA2 gene mutation, and it is poor prognosis. Whenever there is a HER2 positive, it suggests the poor prognosis. ठीक है. Third type is HER2 positive. There is HER2 positive, ERPR negative, and it is a poor prognosis. Fourth is basal carcinoma. There is HER2 negative, estrogen receptor are negative, progesterone receptor are negative. That's why we call it triple negative. It is worst prognosis. And fifth one is Claudine, that is associated with additional molecule. Now, histological classification of CA breast, this subdivided in two groups, that is non-invasive carcinoma of breast and invasive carcinoma of breast. Non-invasive carcinoma has three types. There is DCIS, LCIS, and Paget disease. That is ductal carcinoma in situ, lobular carcinoma in situ, and Paget disease. Invasive in situ means it does not crosses the basement membrane. That is why we said it in situ. And now invasive carcinoma of two types, that is ductal carcinoma and lobular carcinoma. Ductal carcinoma is most common. 85% patient affected by ductal carcinoma and 15% patient are affected by lobular carcinoma. Ductal carcinoma are subdivided into four groups, that is tubular carcinoma, colloidal carcinoma, medullary carcinoma, and inflammatory carcinoma. Relative risk factors for the CA breast: there is no risk in adenosis, cyst formation, duct ectasia, fibroadenoma, fibrosis, hyperplasia, mastitis, squamous metaplasia. There is a slightly risk of CA, that is 1.5 to 2% in hyperplasia or papillary with fibrovascular core. Moderate risks up to 5% seen in atypical hyperplasia. Inconclusive risk seen in solitary papilloma, radius skull. There is a Mercer classification. The upper outer quadrant is more affected than other quadrant because this having maximum tissue, breast tissue is there. Clinical feature is generally seen in CA breast. It is a painless lump in the breast. Nipple discharge is present, usually bloody discharge is present. Nipple retraction or nipple destruction, which generally is seen in Paget's disease. Skin scoriation, axillary lump, fungating mass in the breast. There may be a skin loss. Metastatic features that's seen in CA breast: first is backache, second bone pain, cough with expectorant, breathlessness, maybe there is abdominal distension, seizures if it is metastasis to the brain. There is a jaundice or malignant cachexia. The investigation should be done in CA. The basic investigation that is we are going to perform, that is CBC, ESR, LFT, KFT, blood grouping, X-ray, and ECG. The specific investigation, the tumor marker CA15-3 or FNAC, fine needle aspiration cytology. It is the best or gold standard investigation for the diagnosis of CA breast. If it is conclusive, then core biopsy or true cut biopsy should be done. Next is mammograph and sonomammography or MR breast can be advised for the investigation of CA breast. Third is metastatic workup, USG abdomen. There's a spread of CA to the abdomen. There's an X-ray of lumbar dorsolumbar spine. Third is CT brain for the brain metastasis, ESR or X-ray chest. Staging. There's a TNM classification is more specific but very complicated. Manchester classification is simple, that is easy to access. The first is growth limited to breast. There is no lymph node palpable. Second is growth limited to the breast, but there is a mobile axillary lymph node on palpation. Third is large skin infiltration with pectoralis fixation, matted lymph node palpable. Fourth is complete chest wall fixation plus metastasis. And it has limitation. Hence TNM classification is better. We will discuss TNM classification in separate video later. Now there is a mode of spreading of cancer. First, cancer is spreading locally by continuity and contiguity. Second is by lymphatic spreading. Early we seen in axillary lymph node palpable, then internal mammary lymph node palpable. In later stage, there is supraclavicular or contralateral lymph node may palpable. Hematogenous spread, there is a lumbar vertebrae, femur, thoracic vertebrae, rib cage and skull are affected. CA breast, there is a transmission of CA breast to the abdominal cavity to transcolonomic spreading, also known as cancer shower to the abdomen. This last is implantation, the post procedural. Okay. Thank you for listening. Motivate me to the study by subscribing my channel. Hit the bell icon for never miss an update. Thank you for listening. We are going to discuss treatment protocol in next video. Thank you.